When it comes to obstetrics and gynecology, for a pregnant woman, one of the most important things that you should be able to do is to monitor how labor is progressing when she's already in labor. Now, this is not really monitoring the pregnancy. When you are monitoring the fetal well-being in pregnancy, there are many things that we can use, like what we call the biophysical profile, and you need to know the biophysical profile, the components, and the normal findings and abnormal findings. This is specifically monitoring labor. So for a pregnant woman at week 37 to week 42 of pregnancy, we call that as STEM. She is ready to give birth. So in that particular time, what happens is that there are contractions that will be happening so that the baby can be expelled. So that will be labor that is beginning. So in monitoring for this labor, we use a partograph, which is a graphical representation of how labor is going and how well the fetus and the mother are. Okay, so it's actually a best tool that will be able to detect in case labor is actually not progressing, because for some mothers they might be in labor, meaning contractions are really happening, but then the labor is just on the same level, it's not going further, and such can actually get to pose a significant threat to both the mother and also the child that is in the womb. How did this pathograph come about? So first, Emmanuel Friedman established the criteria of how normal labor should progress. And he told us that what happens is that for the cervix during labor, the cervix is actually a thick structure. Okay, it's thick like that. So what will be happening is that during labor, the cervix will be doing two things. Number one, it will be thinning. So it will be becoming thinner and thinner. So this thinning, we call it the effacement. And then it will also be dilating. So at the beginning, it is closed. By the time the baby is coming out, it is going to be fully dilated, about 10 centimeters dilatation. That is the full dilatation. Okay, 10 centimeters. Now, the dilatation from 0 centimeters up to 3 centimeters, this one is not significant enough. So it is termed as the latent phase or the early phase. Dilatation from 0 centimeters to 3 centimeters. And then now from 3 centimeters all the way up to 10 centimeters, this is now considered the active phase of dilatation. So what Emmanuel Friedman said is that in the active phase of the contractions, okay, or dilatation of the cervix is going to be dilating 1 centimeter per 1 hour. So meaning that if someone is at 4 centimeters, you expect that they are going to be fully dilated after how many hours? Full dilatation, remember, is up to 10 centimeters. So if they are at 4 centimeters, to go to 10, that is 6 centimeters dilatation needed. So about 6 hours, they should be able to deliver. Okay, so that is how labor was divided according to Friedman. Labor is divided into the latent phase of labor and the active phase of labor. And what defines those is basically the dilatation. So this is what I was just mentioning. You can see here the cervix is really thick and then it is undergoing effacement or thinning. And you can see here it is fully effaced because it has now thinned. And then now the dilatation is happening. Here it is not really dilated, and then it is 1 centimeter dilated. It is about 7 centimeters dilated. Here this is 10 centimeters dilatation. That is full dilatation. Okay. So Friedman told us that for the for the cervix, there's a period of time when dilatation is really not happening that much. Okay, even labor itself is not progressing that much. So you can see that the slope is really not steep. So this is what we call the latent period. labor is there, but then the labor is not progressing very fast. That is the latent phase. And then there'll be a time when labor quickly rises, and that's the active phase of labor. So what happened was a proposal has been made that in the active phase of labor, labor is going to be progressing 1 centimeter per 1 hour. So this partograph was actually identified that is a very good tool to be able to identify abnormal progress in labor, according to Friedman. Okay. And then what happens that if Philpott also came in and put something else on the partograph besides the progression of labor, which Friedman put. He also included uterine contractions over a period of 10 minutes. So this is another component that you'll be able to see on the partograph. So in 10 minutes, how many contractions is the woman experiencing? And we are going to be using different things to be able to show how many contractions the woman is going to be experiencing in 10 minutes. Please take note of that. So how you really count this is that if the mother feels a contraction, you give her stones. If she feels contractions, she gets a stone and she puts, let's say, in a dish or a bucket. She feels a contraction, she puts the stone like that. So over a period of 10 minutes, you count those stones, you find how many there are. Okay. So besides that, Philpott also included parameters to talk about the well-being of the fetus on a partograph. That's a fetal condition, which included the fetal heart rate and also the presence of caput and molding. We'll talk about what molding is. Okay, molding is important because it helps us to tell the degree of cephalopelvic disproportion, and it's an important topic that you again need to understand in obs and gyn, cephalopelvic disproportion. Okay. Besides that, there are also lines which were included on the partograph, which we call the action line and the alert line. So if these lines are crossed, it means that the mother or the fetus is at risk. Okay. So for these lines, they were put in such a way that if someone is at a low level hospital, if they cross this line on a partograph, they need to be transferred to a specialized hospital or a hospital that has got good equipment in order to help this woman to be able to manage that labor. Because for rural centers, if you cross these lines, the action line and the alert line, you might not be able to help the mother, let's say if she needs a cesarean section. So that's why she should be now taken to the hospitals that are higher level. Okay. So this is showing, this is what we call the alert line, and then this is the action line. So the partograph should flow like that. If it crosses these lines, okay, it crosses this one or it crosses this one, it's a problem and it is showing that you need to really do something. Okay, you need to help the mother because she's at risk. So therefore, on a partograph, you don't plot a partograph for the latent phase of labor. Because for the latent phase of labor, it can actually take long. It can go all the way up to 8 hours. For you to just move from 0 centimeters to 3 centimeters, it can take that long. So you plot a partograph starting on the active phase of labor from 4 centimeters up to 10 centimeters. That is why if you look at the partograph, okay, itself, so you are going to be starting from 4 centimeters dilatation here, 4 centimeters. This one is starting at 3. The standard WHO will be able to start, okay, the standard WHO, remove the latent phase, and we begin the active phase from 4 centimeters dilatation instead of 3 centimeters because that's where the latent phase is actually ending. A partograph is very vital in that it is going to assess labor at glance and to help us to detect abnormal progression of labor. It will also help us to prevent prolonged labor. As you will see when you discuss, prolonged labor poses risk to the fetus. Okay? The fetus can actually even be in what we call, uh, can have what we call asphyxia. Okay, and then it can also help us to recognize cephalopelvic disproportion. Maybe the reason as to why the child labor is not progressing is because the child is bigger than where the child is supposed to pass through. Okay, there's disproportion between the fetus and the pathway, and then it can also reduce the incidence of cesarean sections because you are noticing it very well. You are really monitoring how the labor is progressing. Okay, so in case there's anything that has to be done, maybe you need to do some augmentation of labor. So to augment is to support. Okay, so for labor you can either induce it or you can augment it. Things that you see in induction of labor includes you getting to break the membranes. Okay, you've noticed that this woman is at term, let's say at 40 weeks, but then she's not in labor. You can go in with your fingers and then rupture the membranes and then give the mother oxytocin, that is inducing labor. Augmenting labor is the woman is already in labor, but now labor is not progressing as much as it should progress. So now you give her oxytocin to help it to move faster. That is augmentation of labor. Okay. So a partograph is also highly effective in reducing complications and make observations and recordings of fetal-maternal condition more objectively. So those are the advantages. Now, what are the principles of a partograph? Number one, active phase of labor is going to commence at 3 centimeter dilatation. Okay, but of course on a partograph we will be using 4 centimeters. Latent phase of labor should not last longer than 8 hours. Okay, the latent phase of course can go up to 8 hours. I shouldn't go beyond that. Okay, if it's going beyond that, you need again to help the mother, maybe to augment the labor. During the active phase, the rate of dilatation is going to be happening 1 centimeter in 1 hour. And then the vaginal examination should be performed frequently. Normally, you do a vaginal exam for a woman in labor 2 to 4 hours every after 2 to 4 hours. Okay, the activity of the uterus and the fetal heart rate should be accessed every 30 minutes, and it should be used for every woman who is in established labor. So a partograph should be opened for every woman who is in labor. Now, what are the components of a partograph? Number one, you have got a mother information on top, and then you have got a fetal well-being information. Fetal well-being information includes the fetal heart rate, the character of liquor, that is basically the amniotic fluid, and then molding. We'll talk about that. And then you have got labor progress. Okay, the labor progress part is showing you the dilatation, the descent. Descent is basically the baby's head going down in the pelvic. This is the pelvic. Okay. So how much is the head of the child or the fetus going down? And then you have got the contractions of the uterus. That is the labor progression. You have also a component for the medications like oxytocin. Oxytocin might be given to either augment or to induce labor, even painkillers because these women are really in pain during labor. For example, pethidine. And then there's also a component for the maternal well-being. So I've got these five components. The maternal well-being includes the BP, the pulse, the temperature, okay, also the urine output of the mother. So now let's look at how you can record all these different components. So when you're recording a partograph, the first thing is you're going to begin plotting at the 0 hour on the partograph. Okay, you can see the axis here, the x-axis is actually representing the time. So please you start at the 0 hour. So let's say you are starting, labor started at 10:45. So at the 0 hour, that's where you are going to put 10:45. And then each line is going to be taking an hour. So here that is 1 hour, that will be 11:45, and then this will be 12:45, this will be 13:45, 14:45, and going like that. But start at the 0 hour. Okay. The second thing is that all entries made are in relation to the time when the observations are made. So all the entries. Let's say for example, you started at 10:45, right? At 10:45, let's say you gave also oxytocin, and then you also did a vaginal exam. So you need to show that the findings. Let's say for the vaginal exam, you found that the dilatation was at 4 centimeters. So we're going to put 4 centimeters there. And then let's say the urine output was also measured, and let's say it was 100. You're going to put that 100 also on the urine output. Okay. Also, all other observations that you found should be made here. Let's say 30 minutes later, you now measure the fetal heart rate. You should be able to record that fetal heart rate. So depending on the time that you have done it, that's when you should put it on this partograph according to the time. The first thing is that you should write notes, and they should be legible. Okay, you should be able to read. They should be dated and timed. So on top here, there's actually the information for you to put the time, the date, and such, and then enter the outcome of the delivery. So even after delivery, you need to enter your details. Please, you enter the details after delivery here. Don't go to this space that is empty because you want to be clean. No, you write here. It is for a purpose. You are closing the partograph. That's why you write the information. So the information that you're going to put here includes number one, the mode of delivery. So you are going to see who actually put the time of delivery. You put, that's the first thing that you record. Time 17:45 you record. And then the mode of delivery, MOD. The mode of delivery, normally it is a spontaneous vaginal delivery, but in case it wasn't a spontaneous vaginal delivery, you put maybe it's C-section, CS, you write there. And then you're also supposed to put the weight, okay, the weight of the fetus, because once no, it's no longer the fetus now. Once the baby is born, you quickly go and measure the weight. The baby shouldn't be with clothes when you're measuring the weight. And then you record the weight there, okay? And then also record the sex, okay, female. And then record the GCS score immediately at birth and then 5 minutes later. At birth, normally the GCS score is not going to be the normal one. Okay, it will not be 10 out of 10. Instead, it's going to be 9 out of 10. And then at 5 minutes, that's when it becomes normal 10 out of 10. So that's how you write it. GCS 9 out of 10, 10 out of 10. But of course, for the 10 out of 10, you need to wait 5 minutes later. All right. So those are the recordings that you make on a partograph. It's very, very important that you understand all those components. So let's start with the maternal or the mother's information that is on top. For the mother's information, there's a component for you to put the name, the age of the mother, the parity, okay, and then the gestational age of the baby. So what is the gestational age? Let's say the pregnancy is at 38 weeks plus 2 days. So you need to record that. And you need to be able to, if the mother tells you I'm 38 weeks, you need to ask her so that you do the calculation. You can use the Nagel's rule. Okay, the last normal menstrual period, and then you do the calculation. Either you add the 9 or subtract the 3 and then add 7 days. That will give you the expected, okay, that is going to give you the expected date of delivery. Then the girl's rule actually gives you the expected date of delivery. Now the calculation of the gestational period, you are going to again ask the last normal menstrual period, and then you start now adding numbers. Okay, you start adding numbers like that. I believe we know how to calculate the gestational period. You need to be able to do that, because when I was at fourth year, one question that came was just like that. They gave a question, and then they asked for you to calculate the expected date of delivery, to calculate the gestational age, and then started asking other questions there. So what is parity? Okay. The other thing that you include is the date and the time of admission. When was the mother admitted? And also, in case the membranes have already ruptured, there is also a part for you to put the rupture of membranes. But in case the membranes have not ruptured, That one, it means it's not something that you should be able to worry about. And there is also a part for you, but the short antenatal history, normally the photograph that we use in our setup doesn't have that one. Okay, so please, this is the information that you're able to put on the photograph, and it's very important that you write it well. Okay, so there's the part as I was saying that you put parity. Actually, you are going to put a parity and the gravidity. So, what is the difference between parity and gravidity? When you talk about parity, so let's say a woman has had 4 children, right? The woman has 4 children, and then this is the fifth pregnancy. This is another pregnancy that she has. So gravidity, that is G, is the total times the woman has been pregnant, regardless of the outcome, including also the current pregnancy, that is gravidity. Okay, let's say this woman has had 5 pregnancies, and then of these 5 pregnancies, the first pregnancy she gave birth to 2 babies. It were the twins. Okay, let's say of the 5 pregnancies, there's 2 sets of twins. 2 sets of twins. So meaning that 2 pregnancies, you have got 4 babies, isn't it? Because it's a set, 4 babies. So for the 2 pregnancies, 4 babies, and then we're remaining with the three. Let's say for the three, one child was born before the age of viability, meaning that it was a stillbirth. The age of viability in Zambia is at 28 weeks, for the WHO is at 24 weeks. So let's say a child was born at 23 weeks. So that one was a stillbirth. Okay, one stillbirth. And then let's say now the other one was actually the child was born and died. The child was born at birth but died. Okay, so one death. And then you also have now one surviving singleton. Okay, a singleton. And then she's pregnant again. She's now pregnant. These were previous pregnancies, but she's now pregnant. So because she's now pregnant, so this is a G6. Okay, gravida 6. Because she's also now pregnant. Why is it gravida 6? Because she has had the 6 total pregnancies, including the current one. That's a 6. And then for the parity, parity is the number of pregnancies that have reached the age of viability. Okay, the age of viability. So let's say this woman right now, she's pregnant and she's at 38 weeks, 2 days. So this woman, the pregnancies that have reached the age of viability, these 2 sets of twins, this one that died also reached the age of viability. The child was born but died. This singleton and this pregnancy has also reached the age of viability. So just accept a stillbirth is not considered in parity. Okay, it's not considered in parity. So please take note that for the twins, okay, for the twin pregnancy is considered as one parity. So because we had 2 sets of twins, that is one parity that makes it two. So this one it's a total of 4, parity 5. So this is G6 parity 5, G6P5. The stillbirth is just what is not considered in the parity. I hope that makes sense. So that is G6P5. Take note of triplets, twins are considered as the parity 1, P1. So you record that information on top. And then you now have a component for the fetal information. The fetal information, you have got the fetal heart rate, the membrane. Okay, if the membranes have ruptured, if the membranes have ruptured, then you'll be talking about amniotic fluid because the membrane is no longer there. But if the membrane is there, you put I, it means that the membrane is intact. If it's not intact, it means it has ruptured. So if it has ruptured, now you talk about it, the color of the amniotic fluid. We talk about that. And then you have got the molding. Okay, the molding. All right. So for the fetal information again, remember steady, there is the fetal heart rate, and the other components. So for the fetal heart rate, you are going to use uh, a fetoscope or PNAD stethoscope, okay, which is this one. The normal fetal heart rate is 110 to 160 beats per minute. And you record the fetal heart rate every after 30 minutes. Every after 30 minutes. Okay? So for the fetal heart rate, it's not supposed to be constant, and it's important for you to understand that. You can't have a fetal heart rate just at 110, 110, 110, 110, 110. That is not okay. Every after 30 minutes is just the same. That's not okay. So you should have accelerations and decelerations. That's the normal fetal heart rate. Okay? Very important to take note of there. So when you are recording the fetal heart rate, you are supposed to you use you are going to be shading a circle like that. All right? That's important. So you are going to put, let's say, at 30, at the beginning, let's say it started at 10:45. The fetal heart rate, let's say, was at 1:30. You are going to shade, and then let's say after 30 minutes later, you are going to shade again. Let's say it went up. 30 minutes later, you shade again. Okay, you continue like that. Please take note after 30 minutes. And then you have got now the membranes. So if the membranes have not ruptured, you are going to put I. I means intact. So there's actually a part here for the membrane. Let me just make it larger. So there's a part for the membranes. You can see there amniotic fluid showing there. So if the membranes are intact, put an I. And you are going to be looking at this when you are doing the vaginal exam. The vaginal exam is done every after about 2 hours, 2 to 4 hours. Okay, so you are going to put an I. But in case the membranes have ruptured, you are going to now use the other letters. If the membranes have ruptured and then the amniotic fluid is clear, you are going to put a C, just like here you can see a C, 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 C. That's clear. And then if the amniotic fluid is stained with meconium, meconium is the poop of the child, okay? Then we are going to put M. It means it's meconium stained. And this is dangerous because it can mean the child can actually aspirate that meconium, leading to the meconium aspiration syndrome. And then if the liquor is not present, you put A, that is absent. And then if it is looking red, it is stained with blood, you are going to put B, and that's also dangerous because it means something is happening there. So that is for the amniotic, the character of the liquor. And then there's also molding. Molding is basically how the fetal head is moving. Because when the child is actually moving through, passing through the pelvic bone, these are the sutures of the child. If the sutures, the bones, okay, are like that, the bones are separated, the molding is 0. And then if they come and touch, the sutures touch each other, that is a plus or 1 plus. Okay, they are touching each other, but they are still separated. And then they can also come and a bit pass like that, they overlap a bit. So that is a plus plus. And then if the overlapping is so severe, okay, and this can be very dangerous, that is plus 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 or 3 plus. That is what we call molding. And the part for molding is also there, okay. So that is what we call modding. So the normal should be at least up to 2 plus. Going beyond 3 plus, it means that there's actually obstruction. So the child is finding it hard to pass through the the pelvis. And so that is why the head has overly overlapped. So you feel this when you are doing also a vaginal exam. Okay. So you can see 0 plus modding. Then there's 1 plus, the bones are just touching. There's a 2 plus, they are just overlapped. 3 plus, it is very much. So use a finger like that. Okay. So the excessive modding may actually tear the dura mater, which are the surroundings of the brain. And that is going to, and including also the underlying vessels can also be torn. So that can be lead to bleeding, okay, in the bleeding in the brain. Okay, so that is what can happen. So again, for the molding, there's a part that is supposed to put the molding of the brain, I mean of the skull. Okay, it is actually showing here. Hope you are able to see that. Okay, there is a part here for molding. That's what's supposed to be putting. Is it a plus? Is it a plus plus? And such. Okay, so that is that with the molding part. And then next, for the fetal information, the fetal information is done. And then the next, we are now going to go to the, please make sure that you put for modding, right? Is it a plus? Is it a plus plus? Is it a zero? That is, it's even showing there. Okay, that's a part for modding, right? Just below the amniotic fluid. Next, now you go to the labor, the progress of labor. For the progress of labor, you've got cervical dilatation, the descent, and the uterine contractions. Okay, so the dilatation, you have got the latent phase which is 0 to 3, the active phase which is 3 to 10. So for dilatation, when you are putting, you use an X for the dilatation. Okay, you use an X. For the descent, it is plotted on the zero, on the is plotted as a zero axis. So the you use actually a dot for the descent. The descent is here. You'll be going like that because descent is really showing how the child is going down, down. Okay, we'll talk about that. So what you do is for the dilatation and the descent, you first do the vaginal exam and then you record the dilatation and the descent. Because how are you going to tell that the child has moved or the dilatation has happened like this if you've not done a vaginal exam? And this is done 2 to 4 hours. Okay. So for the cervical dilatation, it is going to be performed every after 4 hours normally. Okay, every after 4 hours. But depending with the, remember we said 2 to 4 hours, so sometimes you can be performing it every after 2 hours. Actually, even the partograph is going to show, the partograph that you are using will show when you are doing the vaginal exam. But of course, for the exam sake, they will remove that part which is showing the time that you're supposed to record. So you just need to know yourself. For cervical dilatation, remember you use an X. So when you go in with your fingers, if your fingers are just together when you push them in the cervix, that is about 2 centimeters the dilatation. If you make uh, a bit of, you can at least abduct the fingers just a little, that is 4 centimeters dilatation. If you abduct them much, that is 6 centimeters dilatation. And then if they are nearly making 90 degrees, that is 10 centimeters dilatation. Okay, you can only tell this when you've been doing this for long, and normally for students you don't do that one. Okay, so that is for the cervical dilatation, and then you'll be able to put it. So for example, when you started, let's say at 10:45, cervical dilatation was at let's say, now remember you start a partograph when someone is in the active phase of labor, meaning they're starting from 4 centimeters. Okay, so let's say when you started it was at uh you started at 10:45, but then you noticed that the dilatation was still at 3 centimeters. And then you repeat, let's say after 2 hours, because normally you do this 2 hourly, okay, or 4 hours, but normally it's 2 hourly. So after 2 hours, you repeat, it's at 4 centimeters. Let's say after 2 hours again, you repeat another 2 hours, repeat that's after 4 hours, it's still at 4 centimeters. So that is still the latent phase, okay, because the dilatation is really not changing. And then after 2 hours, you do it again, you see that the dilatation has now gone up to 7 centimeters. So that's now the active phase of labor. You shouldn't cross this line. If you cross this line, it means that it's danger. This labor is not really progressing. Okay, so that is for the cervical dilatation. The descent is assessed on doing palpating the abdomen. Okay, you need to do a abdominal palpation, and it is divided into, so you are going to be palpating the head of the fetus, and it's divided into 5 parts. Okay, it's divided into 5 parts. and it is assessed also every after 2 hours or 4 hours. Okay, 2 to 4 hours. So what you do is that you're going to be using your fingers to palpate. You know where the head is. Okay, the head is actually down. So if the head is mobile, it is above. We call that as a 5/5. So it's actually not engaged. So 5/5, if you can feel the head, like you put your fingers, you can see that the way these ones are, all the fingers can feel the head. So that is a 5/5 above the pubic symphysis. So we say that is not engaged. If the head goes a bit inside, the head has now gone inside, you can only feel two fingers above. So only two fingers can be felt. You can see only two fingers can feel the head because the head is actually inside the pelvic bone. So we call that as a 2/5 in so this is 2/5 above the pubic symphysis, or 3/5 engaged. 3/5 means that you can't feel three fingers, so meaning the head is actually inside three. I hope you are getting this. So I've got 2/5 above the pubic symphysis, or 3/5 engaged. Do we get that? Okay. 2/5 above. It means that 3/5, the 3/5, the three fingers actually inside, they've gone inside. Okay, the 2/5 is what has remained above the pubic symphysis. The 3/5 is inside. Okay, so that is 3/5 engaged. So starting from 3/5, we call that as being engaged. The head is engaged, it is inside the pelvic. 5/5, 4/5, that one, the head is actually not engaged. Okay, to be engaged means that the head is inside the pubic bone. Hope that makes sense. So engagement, we have got 3/5 inside, 2/5, 1/5, and 0/5. 0/5 means that there's no finger that can feel the head. The head is totally inside. Okay? None of the head can be palpated. 1/5 means that you can palpate the head with only one finger, 2/5 with two fingers, 3/5 with you can palpate with three fingers, 4/5 means you can palpate with four fingers, 5/5 you can palpate with all the fingers. Okay? And for the engagement, it is in relation to the pelvic brim. Okay, the pelvic brim, which is this bone here. Okay, so that is what happens for the engage. So you are going to be able to show the decency again. So again, for the descent, you can also use numbers. So I've got the positive numbers and the negative numbers. Here is the pelvic brim. This is where you use as a 0 centimeter. That is the reference. That is at 0. Going up is minus. Going down is plus. So for example, just being on top of the pelvic brim, that is going to be a -1. And then more up, you can see you are moving -1, -2, -3, -4, -5. And then as you go down, you are going to the positive. Just below that's +1, then +2, +3, and then +4. So the engagement, you are moving from -5 to +4. Okay, so that is that. And on a partograph, you can even see that one for the decency. You can see here you are moving from 3 to, so there is a 0 down and then there is a 3. So how much as the head descended? Okay, this is going to be, it can be 3, depending with the time that you are recording this. Okay, so let's say when the first vaginal exam was done, and then you saw that the descent was uh, this one is actually not a vaginal exam. This is a palpation. Okay, in the palpation, you palpated and then the head was felt, but then it is felt. Let's say the head is at 2/5 engaged, or at 3/5 engaged. You're able to plot that on your graph. Okay, that is the part that you put here. So normally this one goes down like that. As it is going down, you are starting from up, meaning that the descent has not really happened. So let's say at the beginning it was a 3 centimeters descent. And then as you are going down, you notice that you reach to the point where it is 0 centimeters descent. The meaning of that is now the head has fully gone down. Okay, it has fully gone down. Okay, I hope that makes sense. On the descent, just see how down the head has gone. And please, you use a zero when you are plotting descent. And then another thing is you look at the uterine contractions. For the contractions of the uterus, you are going to observe after every 30 minutes the contractions. Okay? And then assess the frequency, the duration, and each square, which is basically here, that's the part that shows the contractions. Each square is going to represent one contraction felt in 10 minutes. One contraction felt in 10 minutes. Okay? So for the duration, you are going to shade. The duration will determine how you are going to shade the circle. So let's say you have had contractions, right? So I've got mild contractions, moderate contractions, and strong contractions. Mild contractions means that the mother is experiencing contractions, but those contractions are happening for less than 20 seconds. If the contractions are happening between 20, so the contractions have been happening for 20, between 20 to 40 seconds, that is moderate. So for the mild, you are going to put these dashes, okay? For the moderate, you put lines. And then if the contractions are greater than 40, those are strong contractions, you literally shade, okay? That is what happens. So the contractions are going to be recorded every after 30 minutes. You are going to palpate the number of contractions in 10 minutes. So you record every after 30 minutes, but then you'll be palpating in 10 minutes. Okay, let's say you come and palpate, and then you are feeling the contractions. You are not only feeling the contractions, you are also feeling the duration. Let's say for on the partograph you have got okay, like this one. Let's look at this one here. So this is the beginning. Let's say that is at 10 hours. Each box is representing 30 minutes. This come a small box is 30 minutes, 30 minutes, 30 minutes, just like that. Okay. Let's say in the first 10 minutes, you felt the contractions. In the first 10 minutes, the contractions were mild. In other words, the contractions were only happening for less than 20 seconds. Okay. And how many contractions did you feel? So one box means one contraction. And this contraction only lasted for 20 seconds. That's why we put these dots. And then we actually felt another contraction. Okay. So here we felt two contractions and they are weak contractions. They were only lasting less than 20 seconds. Okay. Weak. So in other words, in 10 minutes, you palpated in 10 minutes, and in the entire 10 minutes, you only felt two contractions, and they were only lasting for less than 20 seconds. And then you are going to pause, you try it again in the next 30 minutes. In 30 minutes again, you also felt two contractions which were weak, and each one was only lasting for less than 20 seconds. Okay? And then after another 30 minutes, you did another palpation. Again, the contractions were lasting less than 20 seconds. In that the entire 10 minutes, okay, you're feeling the contractions. They are lasting for less than 20 seconds. But then there were three contractions now which were felt. So that's why the partograph has now gone up. Same here in the next 30 minutes again, you felt the three contractions, okay, which were lasting between less than 20 seconds. And then those were also observed. And then here, after another 30 minutes, when you came to do again the palpation, you felt again contractions. You felt three contractions in those 10 minutes. And each contraction was lasting between 20 and 40 seconds. So, like when you put your hands there, on the abdomen, feeling these contractions, and then you're looking at the time. Okay, they are between 20 to 40 seconds. So for those are mild contractions. That's why we're putting these lines. And then for after that 10 minutes is done, you wait again, and then you come back again 30 minutes later to do again to measure again the contractions. And then again for this one, you felt four contractions, and each contraction was lasting. So in that 10 minutes, you felt four contractions, and each contraction was lasting between 20 to 40 seconds. Okay, so that's why you've shaded four boxes, because you felt four contractions, and each contraction was lasting between 20 to 40 seconds. And then the last one, you felt now these strong contractions. You felt five contractions, and each contraction was lasting more than 40 seconds. So those are strong. So we're going to fully shade five boxes. Okay. Normally should progress like this. You can't have mild contractions, you shade the mild contractions, and then they become weak. You start putting dots. And then you have got mild, and then they become weak. No, it's supposed to progress in this order from mild to moderate and then to the strong contractions. Okay. So that is on the contraction part, and you plot here. Right. So remember it is after every 30 minutes. So there's now the part also for the maternal condition. So oxytocin is usually given as we said, okay, and IV fluids can be given in case the mother is not doing too well, or maybe the mother is losing blood. Actually, IV fluids are always given for these our mothers who are giving birth. Okay. You also record the pulse. The pulse is recorded every 30 minutes, and then the blood pressure. The BP is recorded every after 4 hours. And then the urine that is also passed will be recording it every after 4 hours. Okay. This is oxytocin drip. The oxytocin drip is also one that is given. So for the mother's condition, we have got the vitals that we're going to record. The BP, the pulse, and the temperature. Again, you have got a part where you are putting those details. You can see this part here. So I've got a pulse. So for the pulse rate, okay, you'll be feeling. What's the pulse that you are feeling? Maybe the pulse at the beginning, let's say at 11:45, it was at let's say 80 beats per minute, and then it went to 90, and then it came to 80, went to 90, to 100, to 110. You put them like that, and then you come and join them, okay? And then you also measure the BP. So for the BP, you put the lower limit and the upper limit. And remember, for the BP, you measure after 4 hours. So at least at 10:45, you measured, and then the systolic blood pressure was at 110. The diastolic was at 70. So you write an arrow like that. Usually we write it like this. We write the maximum and the minimum, and then you put like that. After 4 hours again, you come and measure. Okay, the diastolic, you put the systolic is on top, the diastolic is down, and then you put like that. So that's how you record that BP. Okay, and then this partograph also contains the urine findings like protein, acetone. So in those ones you don't normally even measure them. Supposed to be measuring them after 4 hours. So you just put dashes. And then the volume of the urine is normally what we measure. So at the beginning it was 200, so you measure it. After 4 hours it was at 150, you put it there. Okay. And then in case you've been using any drugs, you put also the drugs. Remember, all this is correlating with the time period that you are carrying them out. And the time period, remember, is showing here. Let's say you started at 10:45. This is 11:45. This is 12:45. Everything should correlate. Okay? The contractions, when you're recording them, they should correlate with the time. They should all correlate, including all the details that are down here. They should correlate. Let's say at 10:45, you use 150 mils of oxytocin. So record 150 mils oxytocin. Let's say next, let's say at 11:45, You gave the mother IV fluids. You can put the IV fluids. You can even specify the fluid that was given. Okay? Let's say at 2:45 you gave a painkiller pethidine. Put the pethidine. Okay? So make sure that you just record everything. So that is on the maternal information. So when do you start a partograph? When a woman is in the active phase of labor. Okay? A partograph is used during labor. Don't plot a partograph after labor. Okay, you'll be doing it, you'll be entering the details during labor. So that is what happens. Let's have a practice question here. We have got a case of Maria Ara, who is G4 para 3, who was admitted on the 16th of February 2023 at 22 hours. The hospital number is that. The fetal heart rate was 136 beats per minute. Amniotic fluid was intact. There was no molding. Cervical dilatation was 4 centimeters. The head descent was 4 out of 5. And then 3 contractions. Okay, 3 contractions in 10 minutes, each less than 20 seconds. The blood pressure 120 over 70, the pulse was 70, the temperature was 36, then the urine was 90 mils. Remember, this is at 22 hours. So when you're putting that information on a partograph, you come here. We'll start the time. So at 22 hours, that's why we're going to start as the 0. Okay, so we're going to put the time. Where is that? 4 hours. So it's here. So this is going to be our 22 hours. Okay. Usually we want to put this time inside. So that is going to be 22 hours. 23 hours is going to be here. But remember, even if I'm putting like this, the 22 is actually this line. 23 is this line. This will be 24. 25, that's going to be 01, 02, 03, like that. Okay. Please take note of that. But normally we'll write the time inside the boxes so that it just helps us. So this is going to be 22, this will be 23, this is 24, this is 01. Okay, so let's record the information that you've been told. So at 22 hours, the fetal heart rate was 136. 136. So come and put for the fetal heart rate, the 136 is somewhere here. Okay, that's the fetal heart rate. That will be somewhere where 136 is, between 130 and 140. And then what else? Amniotic fluid was intact. Actually, the membrane was intact. So we are going to come and put intact on the amniotic. So we'll put I there, okay, in that box. And then next, there was no molding. Okay, no molding. So molding is at 0. So we'll put 0 plus there. And then the next one, cervical dilatation is at 4, the head descent is at 4 over 5. So cervical dilatation is at 4. Remember, so for cervical dilatation, you put an X. Okay? The head descent was also at 4, isn't it? 4 over 5. So we are going to, for that one, we use a circle for the head descent. So I've used the circle there. The circle is for the descent and X is for the dilatation. The next is we had 3 contractions in 10 minutes, each less than 20 seconds. So 3 contractions in 10 minutes, each less than 20 seconds. So 3 contractions. So we'll go on the part for contractions. Okay. So for the uterine contractions, it's here. There were 3, each less than 20 seconds. So those were mild. So like that, and then like that, and then like that. Those are the 3 contractions in 10 seconds, each less than 20 seconds. What was the next thing? We had a BP of 120 over 70, pulse is 70. So the BP 120 over 70, so 120. So we'll go at 120. Okay, 120 is over 70. So 70 is here. I'll write like that. 80, 90, 100, 110, 120 is here, and then we write like that, we connect. So I've put an arrow on top and down. And then we are told that the blood pressure, I mean the pulse was 70. So at 70, I'll put a dot. Okay, that's where I've also put the arrow. But I also put a dot. That dot is for the pulse. Okay, what next? Temperature was 36.4, urine was 90. So 36.4, and then urine, the volume was 90 mils. Okay, acetone and the protein was not recorded. So that's the first entry at 22 hours. And then we are told that at 02, so after 4 hours, other measurements were done. The fetal heart rate was at 140. Amniotic fluid is now, the membrane has ruptured. Now it's clear. Okay, so we got the fetal heart rate is now at 140. We'll record that. 140, that is after 4 hours, remember. That is at 02. So 02 is somewhere here. Okay, so make sure that you are going in the right order. So that is at 140. 140 is, it's here, isn't it? Okay, there. That's 140. And then what else? The membranes, the membrane is ruptured and the fluid is clear. So amniotic fluid is actually clear. So we're going to put a C here. That's clear. And then the next one, fetal bones slightly overlap but are reducible. So that's what you need to know about the modern. You have got 0 plus, not overlapping. You have got 1 plus, these are overlapping. Okay, they're actually not overlapping, they're just touching each other. And then there's 2 plus, they are overlapping but they can be reduced. 3 plus, they are overlapping and then you can't reduce them really. Okay, so this is slightly overlap but reducible. What does that mean? That's a 2 plus, isn't it? So that will be on the margin. That is going to be a 2 plus. Okay, let me just look at that again on the modding part. I hope I've not mistaken it. So a plus, okay, plus plus overlap easily and with a reduce with pressure. Okay, that's true. All right, so the next information that we have here is the cervical dilatation is now at 8 centimeters. The head descent is at 2. So dilatation is 8, descent is 2. So remember this is at 0 2. Dilatation is now 8. So we'll come here and put it there. The descent is now at 2. Okay, it's here. And then the next, we have got 4 contractions in 10 minutes lasting more than 40 seconds. So there are 4 lasting more than 40 seconds. Okay, lasting more than 40 seconds. There are 4 contractions. Okay, so for that one, that is again at 0 2. So meaning it's here. So those ones, since they are lasting more than 40 seconds, will shed. Completely shed this because supposed to fully shed them and therefore contractions. But you need to record again the details between this time because for contractions you record after every 30 minutes. So you're supposed to also record what happened between this period. What were the contractions like? Okay, maybe they were still mild, they still maintained, so you're going to shed also like that. Maybe they are still mild for all this period. Okay, maybe they improved a bit and then maybe they became moderate. Okay, so you're supposed to record all that information. But in case you are plotting in the exam, please plot the information that they've given you. And then we are told the blood pressures were 125/80. the pulse was 82. So you also record that blood pressure is 125 over 80. So come here again, 125 over 80. So 80 is the third line. So it's going to be somewhere there. 90, 100, 120. 125 will be somewhere here. So again, like that. And then put also the urine output. Okay. The urine output, you also record it there. The urine output is now at what? 140, and then the temperature is at 6.7. So 140 meals, 36.7 the temperature. Okay. And then you record all the other details. So that is what was happening here. And you continue with the other information that has been given. So at 0250, she delivered a live male. The body weight was 3.6 kg. So now enter those details. So those details, you enter them here. So the time, okay, the time of delivery, 02, what's that time? So 0250, okay, 0250. And then mode of delivery, we are guessing this is a spontaneous vaginal delivery. And then the weight is 3.6 kg. The sex, this is a male. The GCSE score, we are guessing this was a 9 over 10 at birth, and then 10 over 10 after 5 minutes. So that is how you are going to close. It means you after you've entered everything. But remember, when you put this one, the cervical dilatation, you put an X, supposed to connect those lines. Okay, this one is going along the action line, so that one is not really bad. But in case it went like that, that would have meant there's actually a problem there. Okay, so that is really what happened. And for the descent also, you can actually also join these circles, which are going down like that for the descent. Okay, so that is how you get to plot this information. There's also another question for you to practice. Helen M G3 P2. By the way, I didn't even enter the maternal details. You're supposed to enter them on top. The name you enter there. Gravida, let's say. What were we told about this lady? She's a G4 P3. They've already given that information, but they might not even give you that information. So G4 P3, hospital number you enter there, date of admission, enter the time of admission. If the membrane's ruptured, okay, so you record the time of membrane rupture, okay. So that is what you do with this one. So there's another question here. Helen M G3P2, okay, on that date at 09 hours came in, and then that was the data at so came in at 9 hours. At 13 hours, this was the information. And then at 16 hours, that was the information. At 16:45, she delivered. So you plot a partograph and see if the labor progressed normally. Okay. And then this were the fetal heart rate, maternal pulse, the contraction at each particular time. So please plot it's for the same patient. Okay, please plot. We see if you can be able to plot it well. When you plot it, I'll start from here. Okay, you can just screenshot that. Okay, you can also screenshot that. All right, you can also screenshot that, and you can screenshot that. So you get a partograph. You can simply download the partograph on Google. Just type WHO partograph, it will come. You fill it up. Okay, fill it up. You can print it out, fill it up, and then once you fill it up, you can capture it, and then I'm going to be able to look at it. Okay, you can send your answers on our WhatsApp line +260 974 01 6268. Okay, you are going to be able to send your answer to us in case you want us to check it out just to see how you have done it. There's actually another question that you can also practice on. You have got a case of Ellen and Richard, a 26-year-old pregnant woman at 38 weeks and 2 days gestation, was admitted to the antenatal ward yesterday at 04 hours, presenting with labor-like pains. This is her second pregnancy. Her last child was delivered 3 years ago with a birth weight of 2.8 kg and is alive. Her hospital number is at following the examination findings. On admission, that was at what time? 04 hours. These were the findings. You can screenshot that also. Okay. And then at 6 hours and at 10 hours, those were the findings. You can screenshot that. And then at 02 hours, these were the findings. You can also screenshot that. And then at 02:25, she delivered a child. Okay, so that is the information. Now, please forgive me. All this while I've been talking about the GCS. Remember, the Glasgow Coma scale is acted out of 15, isn't it? What I've been talking about all this while is not the GCS but the APGAR score. The APGAR score is a score that you use for a child that has just been delivered. It's the APGAR score, not the GCS score. APGAR score is after 15 and you use it to assess the neurological function of someone. APGAR score is for the newly delivered child. Okay? So here they've given you the APGAR score is 7 out of 8. Please, you need to know the components of the APGAR score. The GCS is for neurological function, and that's about uh, the nervous status of somebody. And then you have got this information. You can also screenshot. Okay? So that is that. I hope you've learned. Thank you so much. So just I'm gonna make a correction here where I put GCS, that is APGAR. Okay, that's APGAR score, not GCS. Alright. So basically this is how you go about a partograph. I hope you've learned. Thank you very much.